Over to you, Avinash.
Thank you, sir. Good evening, all portal members, and I am very glad to be a part of the STEPN program. And I am Avinash, working as an MIC in charge in AIG Hospitals, Hyderabad. Would like to talk about the care of patients on a ventilators. So we modified it as a scenario based, and I wanted to talk about a patient who has come to an emergency with acute pain abdomen since 3 days, shortness of breath since 2 days, and decreased urine output since 1 day. And after being evaluated, he is conscious but disoriented, tachypneic, hypoxic, and on 86% of saturation, on 15 liters of oxygen support with NRBM. He's only maintaining 86% of saturation. He's tachycardic and both hypotensive. And later he was diagnosed as acute severe pancreatitis with MODS. And he was intubated in emergency itself and initiated on mechanical ventilator. And fluid resuscitation has been done, initiated on vasopressors and transferred to ICU for further management. So I wanted to ask a small MCQ that the kind which we have been discussed, a patient of acute pancreatitis, on which mode we can initiate on a ventilator.
So anyone from the audience, they want to answer the question, they can raise their hand, or you can answer in the chat also. So I do see a lot of people answering. Multiple answers A, B, and some answer D also. Okay, there is no single ventilatory mode which is the solution to everything. And you can initiate the patient on either volume control mode or pressure control mode, and closely monitor the ventilator parameters, and also you have to do frequent AVGs to see the gas exchange. So either you can initiate on both either VCV or PCV mode. So in view of the severe ARDS.
And the next MCQ question was, in order to facilitate effective lung ventilation, patient needs to be initiated on what?
Do they need to be initiated just only on fentanyl infusion, or you want to start them on muscle relaxant only, or you want to consider midazolam, or you want to initiate fentanyl followed by atracurium? So I think there is no ambiguity in this question. Everyone has answered D. So ideally, you would go with analgesic sedation first and followed by muscle relaxant, considering this patient is having severe ARDS.
So I just wanted to introduce about what is mechanical ventilation. It is a therapeutic intervention which was firstly used during poliomyelitis in epidemic in Europe and United States in early 1940s and 50s. Since then, there have been great advanced technologies that the negative pressures has been modified as positive pressure machines. So we have come a long way from where we have used iron lung in the polio to treat a poliomyelitis case, giving a negative pressure, to the currently advanced technologies of a positive pressure ventilators, which we are using currently in our ICUs. And mechanical ventilator is a life support treatment, sometimes referred as an artificial respiration, where patients cannot breathe themselves. It supports giving respiration through a machine called ventilator. So it is designed to provide breathing for a patient who is physically unable to breathe. And it can be defined as a technique which gas moves inward and outward through the ventilation to lung. So what would be the indications of putting a patient on a mechanical ventilator? So I would go for acute respiratory failure, upper and lower airway obstruction, apnea, and respiratory arrest, which often there in all hospitals, which is called code blue, and any chronic obstructive pulmonary diseases and neuromuscular diseases like Guillain-Barré syndrome, myasthenia gravis, and spinal cord injury. So the common modes which we are using at the present conditions are volume control ventilation, pressure control ventilation, and pressure support ventilation. So what is a volume control? I just wanted to brief on these modes. Volume control ventilation is, we'll be setting a tidal volume on a constant flow. So how do we keep or predict volume? We have a formula called predicted body weight, which is which varies both in males and females, and it is calculated according to the height of a patient. So that might be in centimeters or inches. So we have kept on centimeter formula. So the formula for male is 50 plus 0.91 into height in centimeters minus 154, and simultaneously that for female it is 45.5 plus 0.91 into height in centimeters minus 152.4. So calculating upon the predicted body weight, we'll be adjusting the tidal volumes in a ventilator. And coming to pressure control ventilation, during pressure control ventilation, two pressure levels are kept constant. The lower pressure level PEEP and the upper level pressure is PEEP inspiration. So the volume and the declarating flow are the resulting variables and can vary dependent on changes in the lung machines. So coming to pressure support ventilation, every detected inspiration attempt at PEEP level triggers a patient's triggered flow cycle, pressure support, mandatory breaths. So the basic settings which we are going to keep when we initiate volume control or pressure control ventilation modes are FiO2 and respiration rate, PEEP. In volume control ventilation, you adjust tidal volumes. For pressure control ventilation, you don't adjust tidal volume, but then you adjust pressure control. So the normal or common parameters to be assessed in volume control modes are peak and P-plat. So we have a small thing talked about peak and P-plat. So this indicates when both high PEEP and high P-plat pressures indicates poor lung compliances, whereas only high peak and normal P-plat indicates any airway obstruction, bronchospasm, and etc. So in PCV modes, mode of assessment of expected tidal volume is more important. So as I told that we are going to initiate on basic ventilator settings, you will be setting mode according to the patient's condition, where patient might need pressure or where they want tidal volume. So you will be adjusting mode according to the condition, and rate. Usually we set up around 12 to 16 breaths per minute. And as per ABG, when there is hypercapnia and you wanted to adjust rate or depends upon the acidosis, we will be adjusting rate. And tidal volume have to be initiated like 6 to 8 ml per kg per body as per the predicted body weight. So inspiration and expiration ratio, usually we go for 1:2 or 1:3. It can be prolonged in COPD cases. So PEEP is around 5 to 10 centimeters, and FiO2 initially we will be delivering with 1% or 100% FiO2. And as per PF ratios being calculated in ABG, you can adjust or decrease them as per the ABG demand. So normal or common alarms we often see in ventilations are high pressure, low exhaled volume, rate, apnea, FiO2. So we have small definition and what could be the potential cause for those alarms to come. So high pressure is when the pressure required to ventilate exceeds the preset pressure. So the potential cause for that is pneumothorax, excessive secretions, or decreased lung compliances. Whereas low pressure is a resistance to inspiratory flow is less than preset pressure. So the cause will be disconnection from ventilator or break or leakage in any of the continuity of circuit. And low exhaled volume is exhaled tidal volumes drops below the preset amount, and the cause will be like leak in system, increased airway resistance, decreased lung compliances. So rate and apnea, as we know that respiratory rate drops below the preset support. It depends upon the settings we have kept if the patient is not maintaining or targeting that. So there will be alarm of rate or apnea, and apnea period exceeds when the set time is more, and the potential cause will be if patient is fatigued, decreased respiration due to any medications by giving more anesthesia, more sedation also. So FiO2 and the definition for that is indicates FiO2 drift from a present range and the potential cause will be change in level of consciousness, disconnected from O2 source or sockets, and break in continuity of the circuit. So the tube which we are going to use on a patient, and we have to select an appropriate size, depends upon the depends upon the category. So for males, the normal size which we use is 8.5, and for females it is 7.5. So we have to monitor cuff pressure every or once in 8 hourly, and usually the cuff pressure should be like 22 to 30 centimeter of H2O, and bilateral air entry should be checked or 5-point auscultation by using 5-point auscultation, because there is more often intubating into right lung. And apart from that, you have to obtain a radiological investigation by doing X-ray. So airway always assess for level of tube fixation as per the physician after obtaining a radiological investigation. And you have to change the position of the tube from one angle of the mouth to the other, so that you'll be preventing any pressure related injuries at the angle of mouth. So we have another MCQ. Suddenly the patient's monitor shows drop in saturation levels followed by bradycardia. Simultaneously, there is low tidal volume alarm of a ventilator. So what would be the first action to be taken?
So as you can see, there is a hypoxemia and it led to bradycardia. So obviously you'll have to find out what is the cause and how are you going to act. You are just beside the bedside of this patient. What would you do? So the first things, basics first. You have to see the continuity of the ventilatory circuit, right from the endotracheal tube to the connection to the ventilator. You have to see for the integrity of the ventilator circuit. Then once you confirm it's in place, then you go and do a suction. And meanwhile, if at all there is a ventilator dysfunction, you will have to connect the vein circuit and ventilate him with the vein circuit. Okay, so the first thing is you have to check for the continuity. So almost everyone has answered the same.
And then the next question is, the patient has been stabilized after readjustment of endotracheal tube and suctioning has been done. However, this time there is continuous alarm of elevated peak pressures. All of the following are causes of elevated peak pressure except
so anyone wants to answer, they can answer in the chat. So I see a couple of answers saying D. Yeah, that is the correct answer. So remaining all these other conditions like kinking of this tubing, bronchospasm, and poor lung compliance due to the severe ARDS, all these will cause elevated peak pressures. So
yeah. Devices and its durations, which we are using for all the ventilation, is the first one goes endotracheal tube. So the duration of the tube is only it has to be changed if it is blocked or you have any visible cuff leak after we check the pressure of cuff through a cuff manometer. And ventilator tubings, as per the standard guidelines, if it has to be changed only when it is soiled or you have any cuts or any leak to the tubings. Catheter mount have to be changed once in every 48 hours. And bacterial filters have to be changed. These filters goes to both inhalation and exhalation ports to the ventilator. So these have to be changed every 48 hours. HME filters have to be changed every 24 hours. Closed suction have to be changed every 48 hours. And remember that you have to change when the tube is blocked or when you feel any thick secretions being obstructing the tube. And we wanted to show a small video stating that what is the continuity of the devices being connected from a patient to the ventilator. So I would like to explain about the various components of suctioning and continuity of devices from a patient to the ventilator. So firstly, it goes with endotracheal tube. So which has both subglottic suction and pilot balloon. So this is the subglottic suction and it is the pilot balloon. So next goes the Y junction, which directly connects one end to the closed suction port. This is a closed suction catheter and this is a catheter mount. And next goes the HMA filter. And next goes two ventilator tubings which are directly being connected. So one goes with inhalation and one goes with exhalation. And directly we are going to connect two bacterial filters. One goes with expiratory valve and the other one goes to inspiratory valve. So this is a device called cuff manometer. So it is used to measure the cuff pressure of an endotracheal tube. Ideally, it has to be between 22 to 30 mm of H2O. So it should be done once in every 8th hourly. So articles what are all needed for suctioning are a sterile tray which is visible there, and sterile glove, gowns, and oral care brush, and 10 cc with normal saline. So whenever we do suctioning, first thing we have to go is do pre-oxygenation delivering 100% FiO2. So that pre-oxygenation helps in delivering 100% FiO2 for 2 minutes. And sorry.
You can go to the slide which has the video. I think you can click on the play button directly.
Yeah, okay, sir. Sorry, sir.
Avinash, just wait for a couple of seconds. I think he's adjusting this slide. Yeah. Just try to play it now. I think you can explain it by just scrolling the images. Yeah.
Yeah, I think it's not supporting. So we'll be skipping off to the slides and I'll explain you. I'll brief you. So So we next have to be seen for suction. The pressure of the suction, the vacuum suction, it should not be more than 200 mm of Hg. So one end of the suction catheter goes to the vacuum suction. So you have to adjust the pressure according to the accordingly, and you should not cross. So one end of the suction set have to connect to the closed suction jar, and the other end have to go for a closed suction set. So this is where we connect the second end of the suction catheter. So after being connected, so gently you have to do a hand hygiene following all 7 steps. So at least 20 to 30 seconds is mandatory, and you have to wear a sterile glove there, and you have to wear sterile apron also. So gently after that, gently insert the closed suction catheter into patient's endotracheal tube. The suction should not exceed more than 10 seconds. It should preferably 10 to 15 seconds. So after inserting it, remember that you should not apply negative pressure while going inside, and you have to aspirate by keeping the negative pressure in a clockwise and anti-clockwise, and do a saline flush to the suction catheter after it is done. We are sorry, there is some net issues. So coming to the suctioning part. So as I told you before, pre-oxygenation and post-oxygenation during suctioning prevents desaturation. How does that work? So whenever you do a suctioning, you only think that we are sucking off all the secretions. But remember that the negative pressure which is being sucking off will suck oxygen also whenever you're doing suctioning. So try to do pre-oxygenation, delivering 100% FiO2 for 2 minutes. As after that, you have to do post-oxygenation also, and select appropriate size of suctioning tube to prevent injury to the lung. So remember, you should not insert your suction catheter more than the length, more than the 1 centimeter length of your length of endotracheal tubes. If at all your endotracheal tube is 40 centimeters in 8 size, you should not insert your suction catheter more than 1 centimeter than that, which means 41 centimeters. So suctioning should, as I told, suctioning should not exceed more than 10 to 15 seconds. Try doing within that. And rotate clockwise and anti-clockwise while giving negative pressure during suctioning. Negative pressure should not exceed more than 200 mmHg. And in severe ARDS cases, avoid frequent disconnections from the ventilator, because we'll be putting on high PEEP, and if at all you disconnect, that may vary in sudden desaturation and it might collapse also. So suction only when necessary. There is no specific guidelines that you have to do endotracheal suctioning or tracheostomy suction that every hourly or second hourly. If at all there are visible secretions are very thick, and if at all there is a specific order that you have to do, you can. But then apart from that, avoid unnecessary suctions. And to obtain the basic CO2 levels, we tend to use EtCO2, which helps in knowing baseline CO2 values on a cardiac monitor. So subglottic suction, as I told you, the pressure have to maintain 22 to 30 centimeter of H2O, and it should be monitored every 8 hourly, and every second hourly subglottic suction has to be done to provide to prevent from the microaspirations which are being drooled out from the oral cavity. So rather than doing open suction, prefer closed, since we are in a COVID pandemic. It helps in preventing aerosol generation into atmosphere. And please do obtain laboratory investigations such as endotracheal culture and sensitivity, and obtaining a mini ball helps after 48 hours helps in detecting hospital acquired infections and treat them accordingly. So coming to sedation, sedation plays a very major role in a patients who are on ventilator. It prevents from agitation, restless and all. So daily sedation vacation after being delivered 48 hours helps in early weaning from a ventilator or to extubate from a ventilator. So in ARDS cases, we paralyze them and provide the better oxygen. Paralyzing a patient in an ARDS picture helps in providing better oxygenation. So tools to assess sedation. So how much we are giving and how patient is tolerating on a ventilation. So the tool which is used to assess sedation is Richmond Agitation Sedation Scale, where we have a scoring of +4 and -5, where +4 is the combative. It means that overtly combative and he's being very violent, which means the sedation which we are giving is insufficient for him. And whereas -5 is unarousable, which means that there is no response when we are talking or giving any physical stimulation, which means either we are being overdosing him. And from the nursing side of aspect, we use a tool called behavioral pain scale on ventilators to assess the pain scale of the patient. So as per the indicators, we obtain scoring according to facial expressions, upper limbs, and compliance with the ventilator. So the maximum scoring in this tool is 12 and the minimum scoring is 3. So we have the other MCQ. In spite of adequate sedation and paralysis and PEEP titration, the patient remains hypoxic. Decision to prone ventilate the patient has been made. Optimal duration of prone ventilation sessions are how much?
The participants, they can answer it into the chat box. So C is the correct response, as many of you have entered it. So usually you prone the patients for around 16 to 18 hours. And after that you give again supine them for around 6 to 8 hours. Okay.
So the other one is contraindications to prone ventilations are all except what?
There are many contraindications to prone ventilation. You should carefully evaluate the patient and always prone the patient when the benefits are significantly outweighing the risks. So as you can see in this, hemodynamic instability is not an absolute contraindication. In patients with mild hemodynamic instability, you can still go ahead and prone the patient. However, in case of significant hemodynamic instability or multiple vasopressors, you should always rethink your decision.
So I just wanted to brief on a prone ventilation. So prone ventilation is only recommended when a patient is in severe ARDS, hypercapnia where CO2 levels are more, and low PF ratios. The benefits includes improvement in ventilation, perfusion, matching, and improvement in gases exchange. As per the guidelines, the recommended prone ventilation in 24 hours is 16 to 18. And after that, you have to make them supine for 6 to 8 hours. And then if you have any ABG recommendations when severe low PF values and all, you can again repeat that. So how do we manage a prone ventilation patient? Since we are making them to sleep on a prone position, so there are tend to have pressure injuries. So try to keep dressings, whatever recommended in organizations, try to keep the dressings to prevent from pressure injuries and provide maximum sedation to prevent from awakening and minimal or optimal RT feeds to prevent from abdominal distension and proper position of head and head to prevent a facial edema and a facial injuries. So coming to CNS part, in a patient who are on ventilator and sedation, neuromonitoring is very mandatory. For conscious patients, you have to monitor as per the tool called Glasgow Coma Scale. And for the patients who are on sedation and paralysis, you have to obtain a pupillary responses every hourly. And sedation and analgesia, seizures, observe for any seizures, delirium, encephalopathy, and CIPM, myasthenia gravis, and GBS. So CVS and hemodynamic, how do we obtain is by having both invasive and non-invasive measures. Non-invasive comes with normal NIBP cuff and all, and if at all you want, and if the patient is in septic shock where you need more inotropes, you have to obtain an invasive line called arterial line. So it helps in monitoring arterial BP and helps in blood sampling. It prevents multiple time pricking and helps in obtaining ABGs. So, and remember that whenever you place an arterial line, try to feel all the periphery pulses so that you'll have any sign of any cyanosis and all. So coming to CVS, whenever there is vasopressors, try to adjust the doses, how much we need to deliver as per the patient's body weight and all. And there should be always remember that whenever you load on NORAD, DEDRI or any kind of vasopressors, there should be a preloading syringes. You cannot wait until the syringe or a plunger comes zero and then load for infusion and all. That might cause severe hypotension. And avoid purchase of bolus doses that might rapidly shoot up the BP. So gastrointestinal tract, early enteral nutrition, if there are high inotropes where your patient feeds are not being absorbed. So how do we assess that enteral feeds are not being absorbed? By doing an RT aspiration once in 4 to 6 hourly. If there is a sign that there is more, more than 100 ml of feed being aspirated, so try going on to as suggested by the doctors, TPN and all. So adequate feeding should be provided to prevent from nutrition deficiencies. RT aspirations can be monitored to check for absorption of it, as I told. So renal parameters, assess for urine output every hourly. Remember that the urine output is also based upon the patient's body weight. So ideally, for all cases, you will be calculating 0.5 ml to 1 ml per kg. If at all patient's weight is around 70 kg, so the baseline is around 0.5. So 35 ml of the urine output is normal. So if at all it is being decreased, try escalating it to doctor. And provide adequate hydration if indicated to prevent from dehydration. Screening of bladder distension if any sudden drop in urine outputs. If at all there is bladder, fullness of bladder, we have to flush the catheters using saline. So coming to endocrine, GRBS monitoring every 4 to 6 hourly, and glycemic control has to be done between 140 to 180 mg per deciliter. So after 5 prone sessions, there was a significant improvement in oxygen status and in gas exchange. The patient was initiated on spontaneous breathing trials. So weaning off from ventilator support has been initiated as we have discussed in the case. So AKI was gradually resolving with the supportive care. And we have the other MCQ question. All of the following are criteria to stop an SBT except.
You can send your answers in the chat box. So very often the doctor says, let's initiate a spontaneous breathing trial. So when do we, what are the various cutoffs we have to say that patient is at a high chance of probability of failing an SBT? So what all parameters do you want to monitor? We'll be monitoring the heart rate, we'll be monitoring the blood pressures, oxygen saturation, and also see for any visible signs of distress. Okay. So the answer is here, the rapid shallow breathing index less than 105 minutes per liter. So rapid shallow breathing index is one of the predictors for the chance of failing or passing through a spontaneous breathing trial. So if at all the rapid shallow breathing index is calculated by dividing the respiratory rate by the tidal volume, and if it is more than 105, the chances of weaning failure is high.
So coming to the main and utmost thing is fast tux PID, where we almost cover all the conditions. So fast tux PID, and to elaborate it, F means fasting and feeding, analgesia, sedation, thromboprophylaxis, since their ventilator patients are being prolonged care. Head and elevation have to be done. Ulcer prophylaxis and glycemic control, spontaneous breathing trials by giving after sedation vacations, bowel and bladder cares involving catheter, and de-escalation of any antibiotics. This is the tool we have to assess daily. So the next main one is eye care. So since we are being sedating patients, we have to provide care of an eye. So cleaning with normal saline from inner canthus to outer canthus, and use of carboxy methyl cellulose sodium drops to prevent any dryness and to prevention of keratitis. So, and you should not let your eyelids open. You have to close all the time. And coming to oral care, you have to provide oral care once in shift, preferably once in 4 to 6 hours. And do use chlorhexidine of 0.2% for oral care. So ET tie have to be changed every 24 hours, and or whenever it is soiled. And do use suction brush while giving oral care, as I have shown you in the video. So back care and skin integrity have to be given. Every second hourly position have to be changed, because all ventilator patients are prolonged patients who will be staying in the hospital, and you have to assess their skin integrity, prevent from a bed sore, and you have to let their skin be moisture all the time. Back care have to be given every 4th hourly, and you have to check beds which are being used to prevent pressure injuries, which is an alpha or nimbus bed. And frequent checking of urine incontinence, immediate cleaning of excreta, because this lets the patients sit in a wet area, so that skin might become more irritable, than it might cause IIDs and it might cause pressure injuries. So all these above elements helps in prevention of pressure injuries related to prolonged hospital stay. So I just wanted to discuss about bundles, because since patients are being treated in the hospital as a sick cases, and they cannot be weaned off within 1 or 2. So since it is a ventilator cases, we tend to keep all the invasive lines. I just wanted to brief about the bundles. So we have different bundles called VAP, which is ventilator associated pneumonia, CLABSI, central line associated bloodstream infection, and CORTI, catheter associated urinary tract infection. So what all comes in prevention of VAP? The utmost for all bundles are hand hygiene. Please do hand hygiene whenever you go to a patient side. Follow all movements of hand hygiene. Follow all steps, 7 steps of hand hygiene whenever you are being contact with the patient. And next comes oral care with chlorhexidine of 0.2%. and head up elevation of 35 to 45 degrees if no contraindications like C-spine injuries and all. And subglottic suction have to be done every second hourly, and maintain the cuff pressure adequately of 22 to 30 centimeter of H2O. Daily awakening sedation, awakening from sedation vacation, DVT prophylaxis, that might be pharmacological or sequential compressor devices, where we tie the cuffs and provide some pressure through a machine called SEDs, and suctioning whenever required, stress ulcer prophylaxis, and monitoring of temperature, daily obtaining of total leukocyte count, and chest X-ray findings. These are all the elements to prevent VAP. So, and coming to CLABSI, as I told, hand hygiene, cleaning hubs with alcohol swabs for every contact. So that have to be done for 15 minutes in a clockwise and anti-clockwise. And you have to check for pain, bleeding, and redness at the site, and TLC counts, temperature. Dressing have to be changed every 7 days or whenever it is soiled. And remember that you have to use a transparent semi-permeable membrane dressings. And daily assessment of a readiness to remove any central line when there is no concentrated electrolytes administration and all. You can assess for that. And coming to CORTI, hand hygiene, catheters properly have to be secured. Ensure that urine bag is below the bladder level. Ensure that urine does not flow into the bladder again, and it should not. The bag should not be resting on a floor. Continuous closed drainage. There should not be disconnections in the catheter from Foley's to the urometer. So unobstructed urine flow, empty the collection bag every 8th hourly or whenever the bag has been full 3/4, and assessment for the necessity of a catheter. So lastly, I wanted to tell, after being all doing this, there should not be a barrier for a patient to communicate with us. So try using signboards where they can communicate with us using the signboards. And please do document whatever the event which you are being doing in a ventilator, which might be the orders, which might be the lab investigations, whatever, or whenever you are changing the mode, whenever you are adjusting the setting. So that must be documented whenever you are being remodifying the settings and all. Yeah, thank you.
So that was a very extensive and very clear communication by Mr. Avinash. Thanks for the presentation. I hope we could put forward multiple issues which we face while managing a patient who's on ventilatory support. Definitely, these subset of patients are critically ill and they require very intensive care. And I hope this presentation goes a long way in just revising our day-to-day practices while taking care of a ventilated patient. And we are open for questions. Any question, you can raise your hand and we can unmute the speaker. And also, you can always send your queries in the chat box.
So any questions?
You can type your questions also. We'll be answering once you type the questions in the chat box. We'll answer them.
So I just wanted to tell, whenever you are doing suctioning and whenever you are handling a patient on a ventilator, or when you are giving care of an eye or you are giving care of an oral cavity, remember that there have to be two personals handling the situation. One will be in a very sterile using techniques, and the other one will help you in handling and or holding all the devices. And remember that you have the methods or things which we are following will help prevention in all VAPs. So remember, you should be very sterile using whenever you are performing a procedure on a patient. So always take help of the other fellow member, and whenever you go for a care, handle the lines properly, secure them. Documentation is very mandatory in this. Any questions you wanted me to answer? Any queries?
So definitely doing such small things diligently on a daily basis will go a long way in management of such critically ill patients. And often small things will determine the overall patient outcomes, doing them on a daily basis consistently. So you can still DM us the questions or send a message. Okay, Avinash, there's a question. There's one of the they're asking about the modes of communication when the patient is on endotracheal tube. How do you communicate with the patient?
Yeah, so there are different signboards where we have small pictures that if at all they wanted to do suctioning, so we'll be pasting a small suctioning symbol on the signboards, and if at all they are feeling drooling or some kind of whatever it may be, the minor things which they can communicate with us are being placed in a signboard so that they can show us whether they're having any abdominal fullness or any discomfort over the back, or they wanted to change us the position, or so they are being kept. And then we have an alphabetic chart so that they'll at least be showing us like formation of a sentence through using an alphabet.
So I just have a question for everyone who's attending this webinar. So how was your experience during the COVID pandemic when we had many such sick patients on ventilatory support? You can just tell us, one of you can tell us your experience managing such critical ill patients. Avinash, what was your experience during the COVID pandemic?
So wearing PPE is only the big challenge for me to handle a patients, and then we have come through many situations where we tend to prone many patients. Suppose my ICU, we have 36 cases. We prone almost 24 to 28 cases in a day. So that has been a great opportunity for me to learn the importance of a prone position, prevention and management of a prone position, and the management who are being and how to manage a patient who are being on a ventilator, because in COVID pandemic, in the first wave, majority of the cases are being on a ventilator. So that is a great experience for me to learn overall management of a patients on ventilator.
And there's one more question by Dr. Krishna Kumar. How do you prevent micro aspiration when you use a normal endotracheal tube and not the dual port endotracheal tube with a subglottic suction? So ideally, you will be monitoring the cuff pressures and maintain an optimal cuff pressure to prevent micro aspirations. Endotracheal tube with a subglottic suction would be more beneficial in preventing such micro aspirations.
The closing remarks are they put in?
So I think with this, we can conclude today's step-in session. So thanks for the participation. Many have logged in spite of the busy duty, and it was a very active participation. Many of the people were responding to the MCQs. So I wholeheartedly thank the ISCCM for giving me this opportunity, and Mr. Avinash to speak upon this topic of care of ventilated patients, which is very important in the midst of this COVID-19 pandemic. Thank you, sir.
Thank you, ICCM, for a great time. Thank you. Thank you, sir. Thank you.
It was until